Hello everyone, this is Dr. Sana. I'm a sports physiotherapist, and today along with Dr. Nitin Kumar Arora and Dr. Karishma Chawla, I'm going to continue this topic of clinical aspect of advanced assessment and rehabilitation of the ACL injuries. So I'm going to take this part of rehabilitation portion of this topic, but before I start my topic, let me emphasize again on the assessment portion of this topic that how much it is important to assess the patient. You know that this is the patient of ACL injury because of the reports and because of the other medical professionals, but you need to confirm it by yourself that along with the ACL injury that has taken place, what are the other things that are hampering the patient, the quality of the muscle, the range of motion, and the psychological aspect, because you are going to, because this is a long way after the assessment portion that you are going to be with the patient, because you know how much long this is going to be. Okay, so before I start this topic, let me just tell you that what are the things that we are going to discuss today. So today we'll discuss about the pre-operative management. What are the things that you need to know? Okay, what are the grafts, how many grafts are there, and what is the purpose of choosing which graft, which is actually a portion of the part of the medical professionals, the orthopedician surgeons. But you also need to know because the rehabilitation protocols some way depends upon the type of graft. And after we discuss about the immediate treatment protocol, the immediate, what are the things that you need to see immediately after the surgery, the reconstruction has taken place, and the return to sports, what are the psychological aspects that athlete or a patient thinks. Okay, so let's start this topic. Okay, so now as everybody knows that the ACL ligament, it is the most injured ligament within the body, and the population group is where this injury is more common is the athletic population. And within the athletic population, female athletes are more prone to get this injury because they have this high knee dynamic valgus angle, which is physiological in them, and also they land up with a hyperextended knee, and when they land up there is increased amount of abduction force that take place on the knee, which places an extra amount of forces and which strain the ACL much more than male. Okay, so the next reason that why females are prone to get ACL injuries is because of the menstruation. So some studies have said that the females, their incidences of getting the ACL injuries are more during the ovulatory phase, and the injuries and these injuries decreases during the luteal phases. And it is a topic of debate, because some researchers have opposed and contradict this topic, and some are in favor of this. So this is a topic of debate these days, which phase is more responsible for the females to get ACL injury. Okay, so not all ACL injuries require reconstruction. The decision of the construction depends upon the age of the patient, because obviously if the patient is younger, if that athlete is younger, he has a long career and has a bright future, so the reconstruction is usually recommended in that case. And other than the age is the factor of the association of the other injuries along with the ACL. For example, if there is a bucket handle tear is present of the meniscus along with the ACL, or the other local lateral ligaments get injured along with the ACL, in that case also the reconstruction is required. And the next thing is if the knee is able to perform the functional activities more than 60%, in that case reconstruction is not usually required irrespective of the other factors. And the last thing is the timed hop test. If that athlete is able to perform the time hop test and he scores more than 80% of the uninjured limb, then in that case the reconstruction also not recommended. Okay, there are some pre-operative issues that should be resolved before the reconstruction, like joint effusion and limited range of motion, atrophy, gait abnormalities, to avoid the arthrophyrosis. And along with this, a history of smoking, high body mass index. These issues has to be taken into account, because these issues would lead to post-operative complications. Okay, so the first thing that you need to control pre-operatively is the hemarthrosis. Okay, so hemarthrosis, it is the immediate response of the tissues after the ACL injury. So you can control hematorosis by the joint aspiration, cryotherapy, elevation of the limb above the heart level, and the compression therapy. So these are the maneuver that should be given to control the hematorosis. So once you have diagnosed the ACL tear, the first immediate treatment is the knee motion. Without any rocket science, you can perform the knee motion as soon as possible to prevent the soft tissue formation. And usually 0 to 135 degrees of motion is required to obtain within the 2-3 weeks of injury, and this amount of motion is obtained before the reconstruction. Okay, because if the immobilization of the knee joint is going to be for the longer duration of time, it would lead to so many changes. It would lead to permanent limitation in the knee joint motion, prolonged muscle atrophy, increase contact pressure of the patellofemoral joint, and there is patellar, infra, and abnormalities of the arthrokinematics of the knee joint motion, and there is a patellofemoral osteoarthritis would be performed. Okay, so for that, patellar mobilization in the superior inferior direction and the medial lateral direction is recommended. And for patients who have difficulty achieving these knee motions, so overpressure exercises has to be given gradually to stretch the capsular tissues to prevent the this scar tissue formation and to regain the motion. Within the knee joint motion limitation, the extension limitation should be the first to treat it. Okay, so for that, hanging weight exercises can be given, and for that you can place a towel or any prop under the foot and ankle so that the knee goes into full extension. And if it is not going into full extension, you can add a 10 lb of weight over the distal thigh so that it would create a stretch on the posterior capsule. And if within a week you are not receiving, you're not achieving the full extension, then you can increase the weight up to 25 lb. Also maintain this position for like 10 to 15 minutes and perform this for like 4 to 8 times per day. Okay, so the next point of concern is the loss in the muscular strength after the ACL injury, which is so evident. So जब भी आप लोग एक quadriceps ACL injury का patient देखते हैं, the first thing that we prescribed is the quadriceps isometrics, which should be done, but at what angle, at what degree you are supposed to do those exercises, that is the point of concern. Okay, so quadricep isometric as a 0 degree of angle at a 0 degree of knee extension is not at all recommended. It should not be done. Why? Because at 0 degree of angle, for example, this is my tibia and this is the quadricep tendon, this is the tibial tuberosity where the tendon gets inserted. If at 0 degrees of knee extension I am doing my isometrics for the quadricep, it is contracting and it is causing the anterior translation of the tibia. And as all of you know that the ACL, it prevents the anterior translation of the tibia. So this exercise is causing a lot of strain on the ACL, which should not be done. Okay, and the same exercise, the same isometric quadriceps, if you do at the 60 degrees of angle or 90 degree of angle, it won't lead to anterior translation of the tibia. At this angle, your ACL is really safe. Okay, so I'm again repeating that quadricep isometrics at 0 degree should not at all be done. It should be done in 60 degrees or 90 degrees if the patient is able to flex his knee. And the same principle this same principle goes after the reconstruction also. Okay, so before the reconstruction, in acute cases, and even after the reconstruction, at the first day you can do the exercises for quadriceps isometrics, you can do, but at 60 degrees to 90 degrees of angle. Okay, so the next exercise is the hamstring isometrics. Hamstring isometrics can be given at 15 degrees of angle, 30 degrees of angle, 60 degrees of angle, 90 degrees of angle. Means starting from the 15 degree till 90 degree you can perform these exercises. Only hamstring isometrics can be performed at 15 degree because they are inserting behind the tibia, and the contraction of the hamstring causes the posterior translation of the tibia, which again provides a safer environment for the ACL. So we recommend those exercises which places no or very little strain on ACL. Okay, and the next exercise is the co-contraction of the quadriceps and hamstring, which is great exercise, which is a very nice exercise. But again, it should be performed at the 35 degrees to the 90 degrees of knee flexion. Okay, and as the phase progress, or as at the end of the phase 1, you can add weight to the patient to more strengthen their muscles. And the weight, the addition of weight and the exercise performed with those weight should be done again from the 30 degrees to 90 degrees. Okay, no exercise at the knee extension motion. So in the last phases of post-operative rehabilitation for around 16-24 weeks, main focus is on the drills. Okay, main focus is on the drills and running program, and progressive plyometrics, hope testing, and special sports specific drills should be started and should look for. And until the patient is able to walk, crutch support is really essential for a proper gait mechanics. Okay, so as all of you know how much CKC exercises are famous for the ACL injuries, but again, at what angle we are providing those exercise, that matters. Okay, for example, squat, which is one of the most famous CKC. So during that, if the patient is doing the squat with the trunk really erect, so that causes the more quadriceps contraction. And as you know, more quadriceps contraction means anterior translation of the tibia, which causes the strain on the ACL. And okay, and if that patient perform that again, that squat in the 35 to 45 degrees of trunk flexion, okay, that causes the more hamstring contraction, and the hamstring contraction provides the posterior translation of the tibia, which places no strain on the ACL. Okay, so the squats with the 30 to 45 degrees of angle should be recommended. Okay, because it doesn't produces the quadriceps contraction. And the next exercise is the forward and lateral lunges. Again, they provide the more hamstring contractions. Okay, but lunges should be done in phase 2, not in the phase 1. Other than the quadriceps hamstring exercises, hip exercises, core training, upper body training can be started during the phase 2, and they should be continued till the pre-operative phase ends. Okay. So this was all about the pre-operative rehabilitation. Okay, so after resolving all these issues of hemarthrosis, limitation in the joint range of motion and muscle strength, our patient is ready for the reconstruction. Okay, so before we move on to the post-rehabilitation, post-operative rehabilitation, I just want to let you know a brief about the graft choice. Okay, so the graft, as you all of you know, that bone patellar tendon graft is a gold standard graft which is used for the ACL reconstruction, and that graft is good. But the problem with that graft is that after the reconstruction is done, kneeling is really difficult for the patient. Okay, so kneeling is a problem that patient usually faces after the BPTB graft. Other than BPTB graft, hamstring graft are the most used for the construction, because hamstring grafts, they have a very good tensile strength. But again, the problem with the hamstring graft is that they extension loss is much more problem in hamstring grafts. Okay, so your rehabilitation protocol would get a bit manipulated according to the choice of the graft. All right. Okay, so after implantation of the graft, our graft loses its strength by 11%. Okay, so from wherever structure the graft has been taken, you need to over strengthen that structure above the base level pre-operatively. Okay, so that after the reconstruction is done and the graft loses its strength, so it doesn't go as much as low. Okay, and the next thing is, after the implantation has been done, the ACL, the new ACL, it undergoes the processes of the avascular necrosis, revascularization and remodeling. Okay, so these processes takes around 6 months to 1 year. Okay, so the new grafts, the new ACL, it behaves like a native ACL after like 1 year. Okay, so during, so just make sure that during the in the beginning of the phase one, in the beginning of the phases of the post-operative rehabilitation, just make sure that the fixation doesn't get loosened up. The graft is well structured, the graft is well strengthened, but the fixation doesn't get loosened up. Okay. So after the reconstruction, our main goal is to prevent the post-operative complication. Okay, so one of them is the formation of the arthrofibrosis. Okay, and control the knee joint effusion is really important. Okay, so these can be prevented by the early knee motion. Okay, so begin your knee motion as early as possible, and for the joint effusion, cryotherapy, TENS, compression therapy, these can be given. Okay, NSAIDs are also given at this point, and immediate knee motion and early weight bearing is really important post-operatively. Okay, so make sure that you move the patient's knee as much as possible. Okay, so to prevent these complications, the early knee joint motion actually it decreases the pain, and it also prevent the formation of the scar tissue formation. Okay, and it decreases the muscle atrophy at the same time, because the exercises that the knee motion, the exercises that you would provide to the patient, they are the only thing that provides the nutrition to the new cartilage, to the new ACL. Okay, so just make sure that knee motion should start as early as possible. Okay, so as I have already mentioned that quadriceps exercises and hamstrings isometrics can be given, but at certain angles immediately after the reconstruction has been done. So other than those exercises, wall slides, heel slides, and seated knee flexion on the chair can be done, and weight bearing exercises like mini squats and weight shifting exercises, they should be started as early as possible within the phase one. And then patellar mobilization is really important, and soft tissue manipulation for the hamstrings muscle, because hamstrings really goes under into spasm after the reconstruction. And in phase 2, stationary bicycling should be started, and in phase 2, quadriceps isometrics at full knee extension can be given. Okay, they can be started now at 0 degrees of extension can be, all other exercises can be started. So after 2 to 3 weeks of reconstruction, 0 to 120 degrees of knee flexion should be achieved. Okay, for and after that, stationary bicycling again, and squats, lunges, and the leg press with from 0 to 60 degrees of knee flexion can be started, and lunges can be started, and balance exercises, proprioceptive exercises, these all should be started. I'm not mentioning the name of the exercises because these are already given in the books. I'm actually giving you fundamental principles based on which you can plan your exercises accordingly. After 4 to 8 weeks, all exercises using weights can be started. Eccentric exercises, concentric exercises using dumbbells, using weight cups, using therabands can be started, in deep knee flexions and full extension. Okay, and main focus after these phases is the on the gait, and on the plyometric training, and on the on perturbation training, because perturbation training is really important, because it increases the neuromuscular strength of the patient, because as you know, in the ACL injuries, the mechanoreceptors also get disturbed. Okay, so for the athlete to get to return to the play, the neuromuscular strength is really required. Okay, after 12 weeks, make sure to prevent the tendinitis. Okay, especially the patellar tendinitis and hamstring tendinitis, depending upon the graft. Okay, and after that, make sure about the landing technique. Okay, teach the correct landing technique to the athlete to prevent the re-injury. Okay, early landing with the knee straight should be avoided. Landing with the genu varum or valgus should be avoided. So in the last phases of post-operative rehabilitation for around 16-24 weeks, main focus is on the drills. Okay, main focus is on the drills and running program, and progressive plyometrics, hope testing, and special sports specific drills should be started and should look for. Okay, so that's all about the rehabilitation portion. I hope you all have got my point of do's and don'ts of the after the ACL injury. The one thing that I really want all of you to know is that always involve your patient. Okay, so I'm sorry, whatever the condition is, whatever treatment you are giving, always involve the patient. Okay, if passive stretching is really give the active stretching first, but if he is not able to perform the active stretching and you are giving the passive stretch, let the patient count. Okay, and if even in the isometrics exercises, let the patient count. Okay, always involve them, do not make them depend on you. So that's all for it. I hope you all enjoyed the session. Okay, thank you so much. Bye bye.